Hello, everyone, and welcome to The Wrap, brought to you by Michigan Medicine Headlines. I'm Dan Ellman with the Department of Communication.
And I'm Dan's co-host, Deanna Norris. Today, we're going to discuss diabetes and the important research and care surrounding it at Michigan Medicine.
Now, before we get into that, go back and do your own research by listening to all episodes of The Wrap you may have missed. You can find the shows on iTunes, Stitcher, Google Play, or any other podcast hosting platform. New episodes can also be seen on the Michigan Medicine YouTube channel and as part of the Headlines Week in Review.
And with that, let's bring in two doctors at Michigan Medicine. Welcome. Can the two of you please introduce yourselves and explain your specific roles?
Hello, my name is Rodika Busui, and I am the Larry D. Soderquist Professor of Diabetes and a Professor of Metabolism, Endocrinology, and Diabetes at the University of Michigan. I am also the Associate Director for Clinical Research in the Casswell Diabetes Institute.
Hi, my name is Joyce Lee. I am a pediatric endocrinologist here at University of Michigan. I'm also privileged to be the Robert Kelch Professor of Pediatrics. And I have an associate director role for informatics and clinical research innovation at the Casswell Diabetes Institute.
Outstanding. So let's get started very generically. What is diabetes and how common is both type 1 and type 2?
Well, diabetes, it's very common. In fact, since we have been talking about pandemics for the last 3 years, I think it's fair to say that diabetes is by far even a larger pandemic than COVID continues to be, as we currently have more than almost 600 million of people with diabetes worldwide, and unfortunately the data is rising. Here in US, the last years continue to see an increase in the prevalence of diabetes, with more than 37 millions of Americans being diagnosed with diabetes. And as we have seen, the incidence and prevalence rates continue to rise. And that is true for both type 1 and type 2 diabetes. And although by far the very vast majority of these cases are for type 2 diabetes, unfortunately, the prevalence and incidence of type 1 diabetes has been increasing lately as well.
Thank you. And can you talk a little bit about the most common risk factors for type 2 diabetes, and also what the most common symptoms are that people may experience with this diagnosis?
No, absolutely. And it's a very important question here, because definitely there are some specific risk factors that are increasing the likelihood of someone to develop diabetes. And among these, being overweight or obese is one of the most important risk factors. However, besides overweight and obesity, many other risk factors have emerged, including different racial backgrounds, with people coming from an African American or Hispanic or Native American background having much higher risks. Additionally, a variety of socioeconomic factors are very important in driving this risk for type 2 diabetes: lack of good food, lack to loss of capabilities of exercising or being involved in physical activity, housing environment as well. As far as an emerging risk factors that we are now exploring for both type 1 and type 2 diabetes is also the COVID. So COVID seems to increase the risk of developing diabetes. And that is true for both type 1 and type 2. We are trying to now, through research, to try to understand what may drive this increased risk. Definitely the increase in inflammation and these changes in various immune processes in the human body that are being stimulated and are being dysregulated by the virus, by the COVID virus, seem to lead to an increased risk for both this type of diabetes. This is a lot of ongoing research here in US and also in other countries to try to better understand.
Are there symptoms that you can share that people might experience who have been diagnosed or who have type 2 diabetes?
Well, so indeed, that's sometimes problematic with type 2 diabetes because one may have higher blood sugar levels without having any symptoms. I mean, when the blood glucose are very high, one will develop sometimes the same symptoms like type 1. They get thirsty, they urinate a lot, they may feel very tired. But when the blood glucose are just, let's say, moderately or mildly elevated, although they do have a lot of potential to create harm and start all these various mechanisms that may lead to complications, some people may not feel anything. Others may have, UTIs like urinary tract infections that maybe develops, or skin infections like fungal infections, or they may note that some of their wounds may not heal as quickly, although they're not very specific. Other may just come with this neuropathic pain. And in fact, here at Michigan, we were the ones who many years ago realized that this very typical burning, shooting pain in their feet at night was a sign of either newly diagnosed diabetes or this pre-diabetes. And that led us to, pioneer the idea of performing this specific test for type 2 diabetes called OGTT, or oral glucose tolerance test. So the symptoms can vary, but they are not as intense, let's say, as for someone who is newly developing type 1 diabetes. And the reason is that they do not lose their entire insulin production by their own pancreas. So the changes happen much more slowly.
Yeah, I'm sure more and more information will be coming in, right, as the years go on about the link there, but that's fascinating. Now, both of you, when you did your introductions, mentioned the Casswell Diabetes Institute. When was the Institute formed, and what is its role and mission at Michigan Medicine?
So CDI was founded in June 2020 and was really designed to harness the strengths of the world-renowned researchers and clinicians that we have here at University of Michigan. There's a variety of scientists, whether they're basic scientists, translational researchers, improvers of healthcare delivery, right, that are part of our enterprise here at University of Michigan. And this was our opportunity to come together and really think about how we can prevent, treat, and cure diabetes, its complications, and metabolic disorders.
Yeah, and I'd like to add to that it's indeed perhaps not too many places in the world can say that they gather the broad areas of expertise through the entire diabetes spectrum, from discovery of these risk factors and mechanisms leading to diabetes, to the understanding of the burden and the mechanisms and the burden of diabetes complications, to the implementation of this finding from the basic research into the clinical research, and then implementation of the evidence that we are acquiring in these large multi-center randomized trials into the actual clinical care. Additionally, the team spirit here at Michigan, I think it's unique, and that makes the entire research and clinical care discovery and implementation so strong. I know that I speak for all my colleagues that we are really very proud to be part of the Casswell Institute, which actually is a summary of all this talent, expertise, and very strong team and collaboration.
But I also just want to acknowledge the Casswell family and all the patients and families that we work with type 1, right? We have a large population here, and I think they have tasked us with the opportunity and the challenge to really think about patient-centered innovations that will impact their loved ones, in current state, not well into the future, but right now, here and now.
Oh, thank you so much, Joyce. That was amazing. And indeed, we don't have words to express our gratitude to all our patients who are participating in all these exciting research studies, whether they are smaller pilots or these larger trials, because without them, we would have never been able to acquire all this knowledge that definitely has changed the way that we deliver diabetes care, not only here at Michigan, but throughout the world. And I think it's important to say how proud we are that we were able to generate some of the most compelling pieces of evidence that have translated into the standards of clinical care in diabetes that are implemented not only here in the United States, but also through the world. I have to, of course, acknowledge as well the American Diabetes Association. I have been honored to be selected as the president for medicine and science, and the American Diabetes Association is issuing this standard of clinical care every year. And those are the models that are being followed by clinicians here in US, but also by clinicians throughout the world. And a lot of this evidence, of course, has been generated also here at Michigan.
That's wonderful. Congratulations. And can you talk about the exciting research and advancements that are being made regarding diabetes and how the Casswell Institute is moving this work forward?
Absolutely. So there are so many things that we can talk about for the last several years that have really changed the life and care of our patients. You know, I mentioned earlier that one of the most important burden of disease is, of course, the development of these complications. And when we look at complications, they can be very broad. They can include the heart and the cardiovascular system, the kidney, the eyes, the peripheral nerves, but also the brain, the feet, as well as many, many other organs. And more recently, as both Dr. Lee and myself have been involved, there are all these psychosocial and psychological complications that or burden that definitely have a role. So from the cardiovascular and kidney complications, the entire diabetes field in the last several years have seen a huge change by the discovery of drugs that for the first time have been able to very substantially reduce the risk of cardiovascular complications such as heart attacks, strokes, and now more recently heart failure. Our team here at Michigan had been instrumental also to identify heart failure being now the most prevalent cardiovascular complication of diabetes, and how these agents and as well as important steps therapy can help people to not advance in the more severe forms that will require hospitalizations and can lead to death. So definitely the development of these newer agents such as the sodium glucose transporter inhibitors and the glucagon-like receptor agonists have been instrumental and have been indeed a life changer for many of the patients with type 2 diabetes. Additionally, we have been involved in many of the trials that led to the coverage by Medicare, for instance, and then of course followed by all the other insurance of these continuous glucose monitoring devices that are measuring the blood glucose of our patients every 5 minutes, that have before not so easily accessible and being quite expensive. And through clinical research studies that we have been involved in designing and implementing, these changes in patients' access have become possible. Of course, that's mainly true for people with type 1 diabetes, and we are now also doing a lot of work to try to generalize the access of these technologies as well as the such as continuous glucose monitor to people with type 2 diabetes. The Casswell Institute, of course, gives us the opportunity to engage in even much high risk, high reward type of research. And I like to acknowledge in this respect the support of the Juvenile Diabetes Research Foundation that made possible the creation of our JDRF Center of Excellence here at Michigan in conjunction with the Casswell Diabetes Institute, where we are now evaluating very novel and state-of-the-art methods in understanding what defines the difference in the risk of developing complications. As we came to understand that, although in the past it was believed that all complications will happen eventually in everybody and the risk is the same, now we have unveiled a lot of facts that tells us that that's not the case, and we are trying to identify risk profiles and specific algorithm by using very sophisticated methods, including proteomic, genomic, metabolomic, transcriptomic, and many other omic type of research in trying to identify which patient may or may not develop a given complication, and then that to be available at the point of care so clinicians can use specified algorithms. So those are just few, and I'm sure that Joyce will want to chime in here as well.
So if we sort of peel back the onion a little bit, talking about research, like why is it so important to look at the chronic complications of diabetes?
Well, because the chronic complications of diabetes are in fact those that are leading to all the burden in our patient's life. I think that with the continuous progress in technology that Joyce probably will also mention, in a way, a lot of the daily life of a patient with diabetes became much easier. However, when one develops chronic kidney disease, when one develops eye disease that impairs their vision, when one develops neuropathy, for instance, which continues to be extremely prevalent, and it's one of the complications where we still have a lot of work to do to find medications that will reverse disease. They lose their capability of feeling, they lose their capability of engaging in daily functions, or like, going to work or doing your activities that you like, gardening, biking, walking. The pain that is present in some people who develop neuropathy, it's so severe that impacts their sleep. It induces changes in mood like depression, anxiety, and may lead to much more severe psychological complication. May require a lot of medication that has a lot of side effects on their own. Additionally, it became now apparent that both particularly type 2, but also more recently, older type 1 are at much higher risk of developing this cognitive impairment like Alzheimer or other type of dementia, which are important. Diabetes may affect the bone health. There is a high risk of fracture. Diabetes affects, as I said, the heart, and can lead to heart failure or arrhythmic events that can lead to sudden death. Diabetic affects the feet, and the foot complications are another huge area of research here at Michigan through both the American Diabetes Association initiatives, but also through an NIH funding Diabetic Foot Consortium, because if a person develops this loss of sensations that can lead to ulcers, they can heal much more slowly and much more difficultly in people with diabetes, and that can lead to amputation. And work done by us and by other colleagues throughout the United States now have very clearly demonstrated that if one person is losing a limb to an amputation due to a diabetic foot complication, the risk of dying, the 5-year mortality risk, is as high as many cancers, such as colon cancer or breast cancer. So those are very serious issues that we are now trying to fight and reverse.
So how is work at the Casswell Institute helping to identify new therapeutic strategies that will improve the lives of patients with diabetes?
So one of the strategies that we are implementing, as I said, is to engage in this high risk, high reward type of research, in which we combine these various multi-omic approaches with quite sophisticated computational medicine and bioinformatic type of analysis to identify not only risk factors and differences in this risk of complications, but also to identify pathways to screen drugs that are potentially already existent in the market that have been developed for other indication, but they can match some of these pathways that we identify that are dysregulated in diabetes and may lead to some of these complications. And then that's possible, again, just because we have such a great team with such a broad expertise that spans this entire spectrum from the bench, from multiomics, from analysis, from working also very closely to our colleagues in computer sciences here at Michigan. They are experts in this new machine learning and reinforced learning type of analysis, and integrating these very large data sets also that are available through our continuous glucose monitoring and pump devices, as well as our electronic medical records, where we have the possibility to mine data on more than 80,000 people with type 2 diabetes that we provide care at Michigan, or more than 7,000 or 8,000 people with type 1 diabetes that are also being seen here, whether they are adults or kids or youth. And I like to give the mic to Joyce by just telling that more recent research that we've done in a couple of large cohorts of youth throughout the United States demonstrated that unfortunately kids, particularly adolescents, can develop complications, which is something that really needs to be addressed because the life expectancy of youth is much, much longer. And definitely the fact that the risk for complication happens at earlier ages that we originally thought requires additional work.
Yeah, and I guess on the heels of that, I want to just acknowledge the role of technology and how much it's changed in the time that I've been, I guess, a practitioner of endocrinology, right? When I came out from fellowship a while ago, I mean, we were doing paper logbooks, right? We didn't have a CGM, a continuous glucose monitor, because they were so bad that you would throw them in the drawer because they didn't give you any valuable data. But we're really in a different era right now as it relates to devices and data, right? So many of us participate, I guess, as clinicians in trying to get our patients to adopt technology. We sometimes have to go insurance to do that, to support that and pay for the cost. But we participate, for example, in the T1D Exchange, which is a large quality collaborative. And, I think it's clear from sort of data that we've looked at here in terms of technology use, as well as national data, that acquisition of the continuous glucose monitoring systems, acquisition of an insulin pump, which helps deliver insulin, and then the integration of those two devices as automated systems, meaning a computer algorithm will gather data from that CGM and tell the pump what to dose, and vice versa, right? The patients have a lot of burden, and we need to use technology to help us, or to help them reduce that burden and achieve outcomes such that they don't have to develop all the complications that Dr. Papasui was just telling us about.
Yeah, that makes perfect sense. So we've covered a lot of ground here in this conversation, which is amazing. And I just want to wrap it up this way. Generically, not just talking about diabetes, but you can obviously associate it with that. Why do you think clinical research is such an important part of what we do at Michigan Medicine?
Yes, that's a great question. And I like to highlight that another of the resources, another important resource available here is that it enables us to integrate the clinical research into clinical care. Clinical research is very important, and there are, of course, a variety of flavors, whereas one does a randomized trial. But sometimes that type of research has to be relevant. Actually, each time the research has to be relevant to clinical care. And by having the research integrated into the clinical care, that allows more people to have access to the discovery. The clinical research is important because if I will take the complications example, we know that sometimes what we find at the bench may not actually be fully translatable to humans. And that has been a lesson and a relatively bitter pill that we had to swallow, 15, 20 years ago, when we were so optimistic that we have cured most of the complications in various animal models of disease in diabetes. And yet, unfortunately, either those pathways that were targeted in animal models were not relevant to humans, or the drugs that have been developed had an unacceptable spectrum of toxicity in humans. And that has, created the premise of a paradigm shift in which we are much more careful now to try to design the human trials that will be relevant and help us to answer this question, to target, of course, better models in which we conduct our initial type of test, whether we validate a certain pathways or algorithm or a certain molecule that may be helpful, and how we prove that that will be, first of all, safe, and then potentially effective in human. Without having this type of tools in clinical research that has also been developed over time, without understanding this, and with this understanding being able to modify many of the trials that we are designing these days, we wouldn't have been able to make the progress that we have made so far. And in addition, because we have this opportunity to constantly readjust our finding and regroup, I'm very optimistic that we will be able to make even more progress across the entire spectrum of complication, as well as in preventing both type 1 and type 2 diabetes, which are very important goals as well.
Yeah, and I think I just wanted to add, relating back to the comment about electronic health records, right? This is sort of the new technology that is really overarching the entire enterprise of the health system, right? We have providers interacting with it. We have patients interacting with it through their patient portals, right? And so, this is sort of the one information technology layer that we have an opportunity to leverage, to use, and to help integrate capture of patient-reported outcomes, capture of self-management outcomes, which we know is really important for improving glucose management, and for bringing interventions to the bedside, to really, take some of those discoveries and say, let's make sure that this is accessible to all in the health system, regardless of who you see or where you are seen. So just want to acknowledge that informatics is a big piece of what we do at CDI. It's sort of at the tail end of the translational spectrum, but again, just want to sort of stress and highlight the breadth of expertise at CDI, which starts with the basic scientists, right? But really ends with the delivery of care, the delivery of reliable and consistent care that we can give here at Michigan Medicine.
Yeah, that's a great way to sum it up. So thank you so much, Dr. Busui and Dr. Lee, for sharing this important information. If you want to learn more about diabetes care and research, go to mmheadlines.org. That's mmheadlines.org.
Okay, so Dr. Lee, we asked you questions about things you're an expert in, and now it's time for some more challenging questions as part of the lightning round, when we ask a guest 4 quick fire questions. Are you ready to go?
I'm ready.
If you could give your younger self one piece of advice, what would it be?
Yeah, so I guess I would say, kind of professionally, what I would say is that computers, data, and data science is sort of incorporated in anything in every industry that exists right now. So I think in my former life, I might have become a computer programmer as well as gone into medicine to really think about how to truly impact outcomes in care.
That's interesting. I like that. All right. So earlier this week, Dr. Marshall Runge mentioned that there will be another pause recommended for standing meetings and other things in August. What is your favorite way to pause when you take a break from work?
Okay, I'm totally geeky, but I love to create Tableau dashboards because I'm so fascinated and interested in data. So I'm not a normal person, but I really do enjoy that. So I will take the time to process all the data for the CDI in the absence of all of my administrative and operational meetings, and I will truly enjoy it.
That's great. And finally, if you could meet one person from history, who would it be and why?
I think Dr. Papasui would be good for this question.
Would you like to take this question?
A person from history.
Yep.
Marie Curie.
Nice. That's a good choice. That's awesome. Well, thank you to both Dr. Lee, Dr. Basui, for being a good sport and sharing your knowledge on diabetes. If you want to learn more about diabetes and all the work surrounding it at Michigan Medicine, go to mmheadlines.org. That's mmheadlines.org.
And while you're there, check out other featured stories from this past week. For instance, there was a closer look at important mandatory training that will make the organization more inclusive, and a nurse at Mott was recognized for speaking up for safety while on the job. Find all that and more at mmheadlines.org.
All right, Deanna. Now, next week at Headlines, we're going to give a sneak preview here. We're going to be running the 3rd annual Employee Virtual Art Fair, obviously in line with the Ann Arbor art fairs that are going on. So I ask you, do you have any artistic abilities?
Let's just say I have the ability to appreciate other people's artistic talents.
That's pretty much where I fall in line on that one. I can take a camera and take a picture of something. I don't know if it's going to look good or not. You know, every once in a while I'll look back on it and be like, wow, that did look good, but I don't think it was anything that I did or I saw. So, you know, you're great at being you accept the art that other people are creating. How's that?
Absolutely. I appreciate art very much.
Outstanding.
All right, it's time for the weekly trivia contest. Last week, we asked listeners, what is the name of the task force that offers tips to employees on how to reduce work-related emails while on vacation? And the answer is the Time and Stress Management Task Force. Congratulations to Brian Wu, who sent in the correct answer. Now, for this week's question, here's Dan.
All right, this week's question is, what is the name of the award Nurse Courtney Maher received for speaking up for safety? Once again, what is the name of the award Nurse Courtney Maher received for speaking up for safety? You can find the answer in this week's Headlines story. And once you know it, send it to headlines@med.umich.edu for the chance to win a prize.
And that's all the time we have for this week. Thanks to Dr. Lee and Dr. Basui for joining us. And thanks, as always, to all of our listeners and viewers for everything you do for patients, families, and each other.
We'll see you next week.